Go.
So this video is going to talk to you about AFib. Personally, AFib is one of my pet peeves that I do like to spend a lot of time talking to nurses about. And I want to give you a scenario that I want you to think about and challenge your current thinking about how you care for patients. So up on the board here, I want you to imagine that this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So I have 11 R waves, 11 QRSs. So that means I have a rate of 110. So think back to one of the first pages or the slides that we talked about, the 6-second cycle count of a rhythm strip. So atrial fibrillation is not one of the rhythms you want to use a 6-second strip on. So if you have a patient in atrial fibrillation at a rate of 110, is your patient controlled or uncontrolled? Now, you all should be in the audience yelling out uncontrolled because it's a rate of 110. But I want you to consider for a minute something else. If I were to simply wipe away one R wave, okay, the waveforms are still exactly the same, but now you have 10 QRSs. So you have a rate of 100. So is this controlled or uncontrolled? So just because I remove one waveform from the end, how is this uncontrolled and this one is controlled? Actually, the way to interpret an atrial fibrillation is to never look at a 6-second strip, count the number of waveforms, and report that to the physician. So I'm going to explain to you what I'm going to do, and then we'll go into the atrial fibrillation slides. So if you consider what is going on in the heart, all of these wavy lines are the atria contracting. You really don't have an organized contraction of the atria, so it's fibrillating. So this is when, in the atria, microclots begin to form. So imagine, I'm just going to draw for a moment here. I'm going to put this first one back. So you have 3 fairly close QRSs, and then a longer pause, 2 close ones, then a longer one. And then when you have a bunch of QRSs that are close together in nature, so you imagine the heart is beating, and then relaxes, beat, relax. It's during that relaxation when you don't have the R waves or when those microclots begin to form. And when you have 2 or 3 or 4 QRSs back to back that are in rapid succession, like bang, 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 that's when the microclots are thrown out into circulation. So I wanted to have you identify in this 6-second strip what is the longest waveform. So I want you to put your calipers on and figure out, now you can't do this because I'm doing this in a video, which is the narrowest R to R and which is the widest. And I will tell you, this one here is the narrowest R to R. So let's imagine we put our calipers on, we compare it to all of the other, and we say there are 7 boxes between that R to R. So this is occurring, this one beat is occurring at a rate of 214. Now I'm looking over, I'm trying to calculate which one is my longest, and it looks like this one is it. And this one is 39 blocks. Again, I'm just making this up off the diagram. So at 39 boxes between each R to R, this would be a rate of 38. So instead of calling the doctor and saying, hi, this is Marcia, and I'm calling to tell you I have a patient on my unit who is complaining of some chest pain, shortness of breath, and they have an AFib around 110, I challenge you to not give that information to the doctor. What you truly have is an AFib at a rate of 38 to 214, okay? So if you have, even if we take this last one off over here, okay, I'm taking it from the other end, so now we have a controlled rate because I have 10 R to Rs. You actually don't have a controlled rate. So you have an atrial fibrillation between 38 to 214. So this is actually the information and how it should be communicated accurately to a physician or whatever the practitioner is. So another thing that I would like to talk to you is consider another definition of what controlled and uncontrolled is. So I'm going to add a few more R waves in here. Let's get rid of these numbers. Okay. Okay. So I'm going to add a few more R waves in here. So what it appears is that I've increased the rate overall. But when you think of controlled, okay, and well-controlled, consider this terminology when you're talking about atrial fibrillation. You always want the rate not to be as high as 110. You would actually, so when you measure these, the blocks between the R to R waves, you want it less than 100. And I'm going to look off. So you want it no more than 15 blocks, ideally. So 15 gives you a rate of 100. Now, a controlled atrial fibrillation, so I want you to consider this, is when you have 30 beat-to-beat variability. So what does that mean? So let's say this patient has a rate of 100. A person with controlled AFib, you want them to have a rate of 70 to 100. So instead of calling the doctor and saying I have a rate of, you know, a range of, what was it, 38 to 214, you want the range you give to a physician to be within 30, okay? A well-controlled is 20 beat-to-beat variability. So let's say you have a patient at 68 to 88. This is a very well-controlled atrial fibrillation. So if you think about your own family member or yourself, do you want your heart rate to be at a range of, and what did I say before, 38 to 214? 38, yeah. 38 to 214, that is 170, 180 beats variability. So it's plus 170. This is not at all controlled, so it's very uncontrolled by the variability, but what you want is always the patient in atrial fibrillation to have their fastest, your narrowest R to R, to be less than 100, and you want them to have a range of 30, and if at all possible, you want them to have a range within 20 beat-to-beat variability.